All right. Hi there, everyone. Again, my name is Ray Dizon. I'm the project coordinator for the National Consortium of Telehealth Resource Centers. Thank you for taking time to view our webinar. This is the latest presentation in the National Telehealth Resource Centers webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Here I'm going to turn it over to Jonathan Neufeld. He is the program director at gpTRAC. Jonathan?
Hi, everybody. My name is Jonathan Neufeld. As Ray said, I'm director for the Great Plains Telehealth Resource Assistance Center. Just to give you a quick little rundown of who we are, I'm sure for many of you, this is the first time you've been exposed to us. Some of you know us well. There are 14 federally funded telehealth resource centers around the country. 12 of us cover regions, and you can see on the map the various regions that we cover. 2 of us are national in scope, and we focus on specific issues or specific topics. The Telehealth Technology Assessment Center in Anchorage, Alaska focuses on technologies, you might guess. And then the Center for Connected Health Policy in California focuses on policy issues related to telehealth. Those 2 allow us a little more of a deep dive on those 2 particular areas. We're going to be hearing from Mei Kwong from the Center for Connected Health Policy a little bit later today. So one of the things that we do is provide webinars like this. We have a monthly webinar series, as Ray said. We also provide more specific consultation and responses to questions about telehealth, the broad range of issues in telehealth. As most of us have learned by now, telehealth is not just one thing. It's a lot of different things to a lot of different people. And right now, many of us are learning that telehealth has a whole lot of applications in the world of emergency response. And there are, even within response to the coronavirus outbreak, there are a lot of different ways that organizations are using telehealth. So we're going to try and provide a general kind of introduction to telehealth in the context of responding to the coronavirus situation. We can also provide lots of other types of introductions to telehealth, more specific to your organization. But for that, we ask that you follow up with us individually and follow up with us directly to your local TRC with your specific questions, because as you can imagine, we can't address everything to everybody. We find that telehealth, the topic is a little bit like an inverted pyramid, in that the deeper you go into the topic, the more narrow your focus is, and the more relevant to one group it becomes, but the more irrelevant to the larger group it becomes. So we really can't go very deep without suddenly, missing a whole bunch of people who may be in a different state or functioning in a different context, or for whatever reason trying to do something different. So do follow up with us with your specific questions. Also, I'd like to encourage you to use the Q&A function, but recognize that there are as many as 5,000 people on this webinar, so we're not going to have a whole lot of opportunity to respond to all those Q&A, all those questions within the context of our time frame here. But what we're planning to do is take those questions offline and respond to all of them, and then post them all back to you in an email as a mass document with all the questions that were asked and all the answers that we provided. We might take the liberty of deleting a few questions like, is this being recorded, and all of that, things that we answer verbally during the webinar. So just please make sure that your phone or your microphone are muted. Most of you don't have access to audio functions unless we specifically give it to you, so not to worry about that. Please try and keep your questions succinct, and recognize that if someone else has answered it, has already asked that question, then you'll probably see it in the follow-up email as well. We don't need to get the same question multiple times, but then again, you don't have to scan every single question before you ask. If we do follow up with your local TRC, as I said before, you can find links to all of the TRCs at our single national website, telehealthresourcecenter.org. And if you go to /contact, then it'll take you directly to the map. You can click on the map, find your TRC, and send us a follow-up question. Do take the time, please, to fill out our post-webinar survey. That helps us get better at what we do. We are recording this, and again, you'll get a link to that recording at the end of the webinar. So if you can't watch the whole thing, you want to review something, or you need to forward that on to somebody else in your organization or elsewhere that didn't get a chance to sit in, please do that. You can find those recordings on our YouTube channel at youtube.com/c/NCTRC, National Consortium of Telehealth Resource Centers. All right, next slide, Ray. We also provide some toolkits on the NCTRC website. We have a specific hot off the press COVID-19 telehealth toolkit. Just answers a lot of general questions and can help sort of get you oriented to the world of telehealth in the context of the coronavirus outbreak and various ways that that folks are using telehealth to respond. You can see the link there. Obviously, you'll have access to the slides, and you can find it on the National TRC website. Next. So here's an outline of today, what we're going to do today. In a few minutes here, we will dive into a panelist discussion with our two panelists. I'll introduce them in just a second, and then we'll hear a little bit about what their organizations are doing specifically, and then also a little more generally ways that organizations are using telehealth to respond, and we'll get to have a little bit of a dialogue with them. Then we will, and that probably is going to go for about 40-45 minutes. Then we'll have time for a specific introduction, because we recognize many of you are sort of coming to telehealth perhaps for the first time in the context of the coronavirus. And we want to have an opportunity to talk a little bit about telehealth technology, just to kind of get your bearings and put a kind of a roadmap, space map out there for the world of telehealth technology. And Jordan Berg from the Telehealth Technology Assessment Center will be providing that for us. And then we'll have a little overview of telehealth policy as it stands today. And this is one of the fastest moving areas right now, because we are being updated by the hour. Hopefully nothing drops while we're on this call, so May's information will be up to date, at least at the time that it's delivered. But May Kwong, our attorney at the Center for Connected Health Policy in California, is going to give us an update, up-to-the-minute update as far as telehealth policy for today. Then we'll wrap up. Again, I'm going to go ahead and apologize up front that just due to the massive size of this webinar and the tremendous response, thank you very much for all of your interest, we are just not going to get to everybody's questions today. But do put those questions in the Q&A queue. And like I said, we will take those offline afterwards. We'll assign them around our TRCs. We'll address them all in writing, and then we'll post that back to all of you in a Q&A document, so that you can find your question and find your answer. And in the meantime, again, encourage you to contact your local TRC and let us help direct you to folks who can answer the questions that you have. I should also say that since we're federally funded, all of the webinars we do, all the information, all the help that we provide is free of charge. If it gets more complicated than we can manage, we do have the option to write contracts and do some contract work. But for the most part, 99.5% of what we do is free and grant funded. So don't hesitate. Don't let cost, since it's not a factor, don't let it be a factor in reaching out to us. All right. Next slide, Ray. First, okay, I'm going to go ahead and introduce our speakers. We have Dr. Saavedra, who's going to be joining us in just a second, and I'll introduce him in just a minute. But for now, I'm going to introduce first Dr. Kerry Palakanis. Kerry is a doctoral level nurse practitioner at Intermountain Healthcare. She's been working on direct-to-consumer telehealth product lines there as a family nurse practitioner, and has a great deal of experience in focusing on rural areas and telemedicine in particular, and is sort of one of the high in-demand sort of crossroads folks in the Utah Salt Lake City area. And she's going to tell us a little about the program at Intermountain Healthcare, just to give us an introduction to herself and to what Intermountain does. And then we'll get back to Dr. Saavedra and have him tell us a little about what he does. And then I'll have some questions for both of our panelists that we can dive into a little more deeply about specifically telehealth, using telehealth and responding to the coronavirus outbreak. So Dr. Palakanis, go ahead.
All right, I'm going to unmute myself here. Yeah, I thought it would be a good idea for me to start by just setting the stage of what we do here at Intermountain and what services we have, and then morph into what we've done in specific to the COVID crisis. If you want to go to the next slide, I don't know if I have access to changing slides. And the next one, and keep going. All right, so just as a brief overview, if you're not familiar with Intermountain Healthcare, Intermountain has 23 hospitals. We have about 2,800 licensed beds, a little over 4,000 total caregivers, including our affiliated ones. We have 185 clinics. And I think what's most important is that we cover almost half of the lives of the state of Utah. So about a 50% chance that if you are looking for healthcare in Utah, we're covering your healthcare. And then we're an integrated healthcare system, so we have an insurance product called Select Health, and Select Health currently has over 1 million at-risk lives in Utah, Nevada, and southern Idaho. And then what I put on the left of this slide is just a little historical overview that we actually launched telehealth services here at Intermountain in 2013, and in 2013 we did a whopping 420 telehealth visits, which we thought was amazing back then. We currently have over 1,300 access points, which would be room kits or carts in facilities throughout our region, and over 500 trained providers in our system. And this year we project we're going to do about 1.2 million telehealth visits. I say tongue in cheek, I think we did that this week alone with COVID, but we're going to probably exceed that this year, given that we didn't plan on the COVID crisis. Next slide, please. I love this slide. This is a NASA slide of the night sky, and I think what's important for people to understand is that telehealth helps everyone, but if you look at the area that's marked off in red on this slide, this is our 8 state, what we call Intermountain region, and where we provide services, although the folks in Alaska know that we provide some services up that way too. We actually straddle 2 of the TRCs because we cover both southern and northern Utah, as well as Nevada, which is in the southern TRC, as well as the service area in the Northwest TRC. But what I like to say to folks is that we treat a lot of patients between light bulbs. As you see, there's not a lot of light bulbs in our area. There's a lot of dirt. So we're handling a lot of folks that are in rural and frontier areas, as well as that nice white blob in Utah that is the Salt Lake Provo valleys. Next slide. So I'm not going to belabor this one because you'll have access to it, but I get frequently asked, what do we do here at Intermountain with telehealth? And the answer is a whole lot. What you see on this slide are the different programs that we have, the different service lines that we have. I personally oversee the Connect Care Urgent Care, which is our online urgent care. It's our busiest urgent care in our system, and last year we did just over 35,000 visits, and this year initially we were projecting doing over 50,000 visits, and I think we're going to far exceed that now thanks to COVID. But some of our legacy programs are our critical care programs that have been around since 2013, and I added the emergency department ED program, which we actually stood up in 12 hours 4 days ago, and is already busy. So we're pretty nimble and agile, but we're also very busy. Next slide. This is actually where I'm sitting right now. We have officeless offices, which is why you might see us going behind here, somebody going behind here. A year ago, they actually created a virtual hospital for our program, and we moved all of the telehealth services into one facility. It's about a 20,000 square foot facility. And the day we moved in, we realized we needed twice as much space. So we're temporarily residing here while we've asked the system to actually give us 80,000 square feet of space to move our telehealth services into, because we just have so much demand. And I'll get back to that in a second as to what we did with COVID. Next slide. Oh, keep going. This is one of these lovely, sorry, I didn't mean to send you our animated slide. So what have we done with for the COVID crisis in particular? I just showed you our virtual command center, and we converted 50% of that into a COVID-19 call center within about a 8 to 12 hour period. We got asked by the state of Utah if we could take on all of their COVID screening calls, as well as we have our own patients within our system. And so we booted out everybody that was in a non-clinical role here, and we moved in about 60 nurses that are working 24 hours a day, 7 days a week, averaging about 3,000 calls a day. At the same time, my Connect Care staff, which is our urgent care, we went from our typical this time of the year 150 calls a day up to 350 virtual visits a day. And so we've had to leverage it in some staff in that area as well. What we've done in particular with COVID is we've taken our tele-infectious disease specialists, and they're really the quarterbacks of our COVID crisis response, along with our telehospitalists that we have here, because they provide the overnight coverage. And we have created a communication system in our command center where all of us are working in sync. As a matter of fact, right before I came to this meeting, I was working on a resulting process with everyone. We've had a lot of our staff that are not currently able to work in their roles because we stopped performing non-emergent services, and elective surgeries have all been canceled system-wide. And so we have a lot of nurses and doctors who are idle right now. And so we have actually brought them in and retrained them into telehealth. And so the nurses are actually working on our call center, and the doctors are working on our Connect Care service. And we're just trying to find alternate ways to mobilize folks within our system. And then at the same time, we have, of course, had a huge response of requests for our video visit programs, so that the providers who can normally see their patients in their clinics, we noticed about a week ago that the no-show rates were increasing and people were dropping off from their regular follow-up visits. And so we decided we were going to deploy scheduled video visits out to providers who didn't previously have that, so that we could maintain follow-up with patients. We have a centralized result management program now where all negatives are handled by a bank of nurses and all positives are handled by the team that I have brought in of providers. And we are also, we own three jets and 5 fixed-wing helicopters. We're the only flight service right now in our region transporting COVID cases, so we're busy with those as well. The other thing that we've done with our tele-infectious disease and telehospitalists, we actually have them providing services to any of our COVID-positive patients in the hospital through telehealth, so that they are reducing their risk factors as much as possible and and are able to stay on the front line. And then the last thing that we're working on right now is a COVID-19 monitoring program using remote patient monitoring, so that when a patient is tested, since we have such long delays between test and actual resulting if they're not in hospital patients, we're able to do an outpatient monitoring of self-reported outcomes and self-reported temperature to allow the patients that are tested to feel that they still are receiving care, and we can maintain monitoring of them and escalation as needed. And then the other bullet point I didn't put on there is that yesterday we experienced 2 earthquakes here in Utah, something that doesn't happen very often. And our virtual call center had to be evacuated twice, once while we were in the midst of doing a telestroke, but our folks stayed on here. So somebody asked me the other day if we could flex in the event that there was a second crisis in addition to COVID, and I guess the powers that be above us decided to test that theory yesterday with earthquakes, but we were able to maintain services throughout those 2 disaster responses as well. And that's what we're doing in Intermountain, just a little bit.
Okay, fantastic. Wow. Ray, can you bounce back several slides to the introduction of Dr. Saavedra? All right, so Art Saavedra is a specialist in complex medical dermatology and is at the University of Virginia, I believe, still health system there. Why don't you go ahead and tell us a little bit about yourself and about what the folks at UVA are up to with regard to responding to the coronavirus crisis. You're gonna have to unmute yourself first, Dr. Saavedra. There you go.
Hear me now? Excellent. Well, hello everyone, and thank you for the opportunity to be with you today and what I think will become sort of our new world order for the next couple of weeks. I serve as the chair of dermatology. I'm also the chief of ambulatory strategy and operations. And what I'd like to talk to you about is what to expect in a system maybe that isn't completely set up in telehealth, how to scale that, and is it in fact possible to do that in a short while. Our system is a fairly mature system, but unlike the system that you heard before, we have only one hospital. We do have a lot of community practices, but we concentrate our care in one location in Central Virginia. However, as a state institution, we are required to take care of, responsible for, and happily so, for a very, very vast area. Generally areas that have high penetrance of technologies and areas where a telephone is really the best we can hope for. So before starting, I really do want to highlight that for those of you that are wondering if you can do this and if it is possible to stand up in a short period of time, the answer is absolutely yes, yes, and yes. Though we do have some very mature telehealth programs that include stroke care, particularly in some areas, high-risk OB. We had concentrated our efforts in very strategic areas that were areas of growth for the health system. So all of a sudden, turn a few pages and you find yourself thinking about COVID. So how do you now turn from strategic growth of certain clinical programs into simply serving every patient in the health system? The first thing I'd like to highlight is, yes, we're doing a few of the things you've heard of before. We have remote monitoring for patients that are at high risk for coming into the hospital. We deploy iPads and other ways of being able to collect patient information from the patient, like temperature, blood pressure, heart rate, glucose, all these other things. And we have a 24-hour operation, 7-day-a-week operation. But I want to highlight that these technologies themselves are just a conduit to something even greater. So the way that we strategically thought about telehealth was to figure out what is the need that we're trying to fill with telehealth. Is it the ability to reach a large group of patients that all have the same concern? Is it the opportunity to reach a large number of providers that have the same concern? Is it the ability to reach the worried well? Is it the ability to reach those who are, actually sick and we're trying to keep from the hospital? And as you start answering those questions, you start thinking about not just what tool you deploy, but in what way you deploy it. So let's step back and sort of think about all of those. If you think about, again, the patient who is actually fairly sick and you actually want to keep the patient at home, that's a patient that you clearly want to think about, very close monitoring around vital signs, other information about contacts at home and general medical problems, flaring of chronic health. So, that is a fantastic platform for what you've heard before, the use of iPads and other ways of detecting vital signs. But we do that very cautiously. And why is that? Again, often the use of these technologies in the wrong population can cause not only just exhaustion of the system, but also increased preoccupation by the patient. So we have carefully selected algorithms where we know based on clinical condition and who the patient is, what kind of technologies they should have. And so roughly speaking, the technology is deployed unequally and with more capacity for the sicker and less capacity for the less sick. I'll give you an example of that. So I've spoken about remote monitoring for patients who are still febrile, maybe short of breath and have chronic conditions. But then what about the worried well? Should they be sending in their vital signs and stuff? And you know what we learned so far is that the answer is probably not. In that population, you want to really highlight the reasons to be concerned and how to reach your doctor, but not allow that type of contact immediately to decrease the amount of anxiety. Instead, what we've created in that group of patients, on the other end, those that are very, very healthy, is a web-based tool where people can at any time go in and talk about contacts, symptoms, travel, and the algorithm specifically points them out to their level of risk as high, moderate, or low, with some instructions as to what kind of care to pursue at that time. So again, I just want to sort of demonstrate the breadth of the technologies, but how to really think hard about how to deploy them. So that's thinking about the patient as individual units. Now let's think about how to address large groups of people, whether they're patients or providers. What we have found is that particularly at the level of providers who may be resource constrained, now we're talking about skilled nursing facilities, assisted living facilities, the real anxiety is around, you know, will you be available if we run into trouble? And so we've created programs where very much like a line that is staffed by nursing, we have staffed that actually with physicians, with pulmonologists, and with infectious disease doctors to really send home the point that we care, that we're really here and available for the patient, but also really to think very, very hard about who should or should not be transferred based on the needs of the patient and what the goals of care may be at that circumstance. That kind of interaction has been actually a gift, in that not only have we been able to have discussions about the care of these patients, but also about the planning for supply chain management. So a lot of questions around, you know, what do I do if I run out of lube masks? What about N95? What about gowns? What about eyewear? And that kind of setting has allowed us to decrease anxiety, not just around the various centers and providers, but also an opportunity to share what each of us is doing around some constraints in the system. Those conferences are done very much like the ones we are doing right this second. It's been very, very collaborative, including nursing, doctors, physical therapists, you know, respiratory therapists. And again, it's been a very, very good way of reassuring one another that we're really in it together, that we're a community, and that we will help each other out. When we have engaged patients at the level of groups rather than individuals, we still have done that over secure platforms, but the value proposition changes, and it's clearly less about specifics of medical care, and it is more about actually healthy living. The concern there is, what can I do or what can I not do? Should I go to restaurants if you know, if I am healthy? You know, what are the risks to my grandmother if she is ill? And so it's been a fantastic opportunity not only to discuss preventative care, but also to dispel myths, because there are many, many myths. And I think as we start discussing the tug between personalized care and that of large populations and public health, we will often find conflict about what we would ask a patient to do in the protection of the community. So those kinds of technologies are slightly different than the ones in which we've engaged large groups of doctors, in that there's a lot of chat, there's a lot of sharing of websites, handouts, and again, the debunking of myths. The last thing that I'd really like to highlight is technology can be, you know, very, very powerful, but it can also be an obstacle if not deployed correctly. What do I mean by that? What is the value proposition that the technology is offering? Is it just visual connection? Is it audio? What exactly are you hoping to accomplish with that? And we have found is that in this time of, again, clinical cancellations and trying to keep people away from the hospital, these technologies are simply the only way that we can take care of patients who who are not coming to the center. So maybe that's a long way of saying never, never waste a crisis to really, get people aligned with changes in technologies. And I'll tell you, it's been a long week, but a week of a lot of learning. We've learned actually from patients specifically what they prefer. We've learned that people actually don't want to come in the waiting room. We've delivered apps where we can text patients who are waiting in their cars before coming up to the visit, and thereby, allowing a completely empty waiting room. So how do we still see patients that need to come in urgently and have an empty waiting room? So again, visual tools, auditory rules, and apps have been very, very helpful to us.
Thank you. So now, thanks to both of you for introductions and some overview of the kinds of things that are going on with all of your organizations. Now we come to one of the most fraught periods of the webinar as we try and transition into some questions. And we've got a few that we kind of came up with before the webinar just to sort of expand our conversation here. I just want to make a few comments about the chat and the questions that we see flying by at light speed here as we're talking. First of all, I just want to say to all of you, thank you for your questions. Just something that I want to point out as a kind of a technological limit, the difference between chat and Q&A. If you're in the Q&A, we will try and address your questions and send that all out. I'm not sure we're going to be able to get everything that's in the chat and address it as a question. So do put your questions in the Q&A list, and you can use the chat for chat kinds of things. Second, we're seeing a lot of themes come up, and as you can all imagine, and Drs. Saavedra and Palakanis, you can imagine as well, as I said at the outset, telehealth is being used for a lot of different things. We haven't had any mention yet of behavioral health. We haven't had a whole lot of mention of the responses that involve folks that really are not COVID-19, but are all the other people. You did mention both of you said a little bit about it, but we're hearing from a lot of clinics that saying, I'm not a site for COVID-19 treatment, but we route those people to our local medical center or whatever, but our patients are very reluctant to come in right now. And so our whole push is to try and figure out ways to address their needs and not have the clinic go under or people go unserved at a time when they're trying to stay at home. Kerry, maybe you can start. What sorts of questions are you seeing coming up? What sorts of ways are people using telehealth beyond just your organization? But what else are you hearing, or what sorts of ways are people using telehealth, maybe not to address COVID-19 specifically, but all of the secondary and tertiary effects of a mass quarantine and shelter-in-place orders?
Absolutely, that's a great question, because I've, in my experience with telehealth, used telehealth in a variety of different ways, and I will forgot to preface my introduction in that while I work for Intermountain Healthcare right now, prior to coming here about 18 months ago, I was a primary care provider in a very rural part of Maryland, really struggling to reach my patients who were underserved and had limited access to care. So I'm very familiar with folks that have needs that are outside of something that a large health system can do. But let me say, as far as behavioral health, there are a lot of resources right now for telebehavioral health. We certainly do that here at Intermountain. We have telecrisis that goes into emergency rooms, as well as behavioral health counseling available through telehealth services. And it's one that lends itself very well to telehealth because you don't have to worry about the peripheral devices such as those you'd need to listen to chest or heart rhythms. And we can take that into a variety of different ways. Right now here in the programs that I'm working at, we have home dialysis patients that we use telehealth monitoring for. And I saw one of the questions that came up about somebody wanting to know what they do with their dialysis patients. Telehealth lends itself perfectly to those patients in the home environment if you're doing home dialysis. We have oncology at home patients that come into the facility to receive their first chemotherapy, and then all future chemotherapies are done at home. And we're both doing remote patient monitoring as well as telehealth management. But really, almost anything that you can do within the acute care setting or in an outpatient environment can be translated out into a outpatient home-based telehealth response. It's just dependent upon the bandwidth of the patient or the cellular capabilities of the patient, as well as the type of peripheral devices you'd need in order to support your visit.
Great. Do you, and I'll address this one to you, Dr. Saavedra, you know, we have there are a lot of things we can do when we have an adequate technological floor under us, but we also are starting to recognize that not everyone has access to internet or cellular networks. And so as in a response, we're hearing at the federal level and a number of state levels, relaxation of the guidelines or the regulations around live video and opening up, you know, basically voice care, telephone care. Is that, what are some of the implications of that, and how might organizations be thinking about how to leverage that newfound flexibility?
Oh, absolutely. I think at the very first junction is honestly the acculturation of the health system in comfort with providing that type of care. You know, we hear about Hipaa, we get trained in Hipaa, we get credentialed every year on Hipaa, so it becomes almost a religion sometimes. And I think the ability to relax that it is very important to sort of educate providers what that means. And by providers, I mean everybody, right, who is going to be engaging the patient, to assure that it is, you know, the right way to engage. So I think in many ways, the acculturation is very important and the first necessary space. But secondly, and again, trying to predict something is the best way of being wrong. But I think we are really going to have to be very resourceful in how we reach patients. And so I think the issues of you know, HIPAA protected networks is a good one to think about, but we don't know how we're going to flood systems. We don't know how we're going to have to recur to other platforms that are perhaps not, you know, approved by the institution at that point. How we're going to use not just the telephone, how we're going to use texting, for instance. How are we going to reach patients that may not have consented to that kind of interaction before? Would they consent now if they knew this was going to be an emergency? So I think that we're going to have to do a lot of work with the culture of medicine around it. The second thing that I will say is that for any provider or any, you know, member of the administrative structure of a hospital, if we hit hard times in terms of the total number of patients that we have to hit, I again urge us all to remember that the use of these technologies that we're going to be talking about today and deploying is really potentially the only way we can reach some patients at all. So if you haven't had these discussions with your cabinet or your executive panel, have them now and be ready, because we just don't know how we're going to communicate.
Yeah, no, I think you're absolutely right about that. We are facing a cultural change, not only in the larger culture, but in the healthcare culture as well. And we have kind of seen that trickling in over the years. And now all of a sudden that the volume is up to 11, and we're going to have to figure out how to do mass culture change on the fly. And that's just going to have ramifications all through the healthcare system, top to bottom. Yeah.
I also think that this new period we're in is going to teach us a lot more about what we actually can do when the pandemic is over, in terms of how we're really going to change medicine. I don't think this is a period where we're going to use telehealth to reach patients and then go back to the way we used to do business. I think this has been an inflection point in medicine, an inflection point in telehealth, and an inflection point in the way that patients will want to communicate with us after we get through this.
Agreed, exactly. Ray, go ahead and give us the next page, and let me just take a look at the other questions that we had set up ahead of time. We're getting I'm going to just address some of the questions that are coming through the chat and the Q&A. We are not specifically, and I know everyone has kind of figured this out, we're not specifically addressing behavioral health today, although as Dr. Palakanis said, huge potential in that domain. If you have questions about behavioral health, thanks for your questions. Follow up with us directly. We'll also address some of those that we can in the Q&A afterwards and send them out. Your local TRCs have all kinds of information about that. It's a whole domain that we focus on, and there is lots to be said there. So do follow up with us specifically about those questions. Secondly, a lot of you have detailed questions in the chat and the Q&A about billing this code, or you know, how are we going to get reimbursed and that sort of thing. It's another whole area that we talk about a lot. And like I said about the inverted pyramid, as soon as we start answering one person's question, 1,000 people say, well, that's not my question. So do follow up with us directly, and we can get you those questions. Don't let the fact that we're sort of taking the 10,000-foot view here convince you that we really don't know what's down in the details. We do, but we just can't go into everybody's details at the same time. So follow up with us directly. There are also a number of questions that people are asking about licensure and credentialing across state boundaries. And as you know, this has been a long-standing issue. There's a lot of work being done, and there are even some sort of last-minute urgent emergency changes. And frankly, I think the comment I would make about those changes are the system is always a little more, if not a lot more complicated than just, you know, saying, hey, we're suspending the rules for this month, because there are layers and layers of rules and regulations in healthcare. It's a highly regulated domain, as we all know. So a federal, you know, loosening Hipaa regulations or suspending Hipaa temporarily, how does that impact all the states that law number one is follow Hipaa? Does that mean that state law is now suspended? Well, the federal government can't suspend state laws. They can override it, but, you know, and we're not sure about all the implications of all those things, and yet we're trying to set up these clinics yesterday. So I guess I'm pleading for a little bit of patience with folks watching, and also just recognizing, calling out the fact that we the TRCs, our panelists here, we are a source for a lot of information, but not all of it at once, and some of it is not even yet known today as it rapidly changes. So we will get to that.
And Jonathan, I think that's a good thing to point out too. You know, before I came to work for an organization that had multi-state practices, my view of telehealth, and that was 10 years of view, was a fairly tunneled focus for the Mid-Atlantic. And I see this a lot on social media, and there's a lot of social media groups associated with telehealth. I think it's very important for folks to utilize their TRCs and be mindful that what the information that you're given through a telehealth or a blog or another group is not necessarily translatable to your state of practice. And that is even more reason why the TRC should be your safety net for information, because I can give you information about the 8-state region that I am currently practicing in, but that may not apply to somebody in Texas or somebody in New Hampshire. So be mindful that the state regulations, even though there's been a loosening in the federal ones, the state regulations are still there and still apply to your practice environment.
Yeah, excellent points. We come across this all the time, and in fact, there are I've seen a number of questions go by. Can you just quickly get me up to speed? Do you have a brief guide for how to do this? And yeah, it's kind of like asking for a brief guide on how to remove your own appendix. You probably, even if it were possible to write such a brief guide, you probably don't want one. You probably would rather get connected with somebody who knows what they're doing and have them work you through it or help you do that. So do reach out to us. our goal as the TRCs is to help you stand up these services as rapidly as possible and answer your questions. We are going to go ahead and transition now to the next section of this webinar, and I'm going to have Jordan Berg come on from the Telehealth Technology Assessment Center. Again, recognizing we have just scratched the surface of all the questions and the depth of expertise that we have with us here, but we're going to, just in the interest of time and what we have available, I'm going to go ahead and bring Jordan on and let him provide a brief overview of technology concerns and considerations in setting up a telehealth program. And then I do want to just remind everybody, May Kwong from the Center for Connected Health Policy will be coming on after Jordan, give us a brief overview. It sounds almost like an oxymoron these days, but a brief overview of policy considerations with regard to telehealth, and she will have an opportunity, and we will all have an opportunity to answer to ask and answer some questions, bringing us up to date. Again, I just want to have everybody recognize it's a huge and rapidly changing field, even now more than ever. We can't answer every question right now today, but we will get to them and do follow up with us, because we are, as Dr. Palakanis said, the information that flows across social media or flies or in groups and whatever, we as TRCs hear this all the time. I'm sure our guests have too. Somebody says, well, we heard from somebody that such and such was the case. And we can realize in our head, oh, okay, I bet that person was from such and such a state, or they might have heard it through this, in this context. Whereas if you're an Fqhc, if you're an RHC, a critical access hospital, a private clinic, all of those things could be different. And if you're talking to this payer or that payer or this state or that state, all those things can be different. And we don't want to discourage anybody in any way, but we just want you to recognize, you know, we try and make things as simple as possible, but no simpler, because when you go more simple than you can go, you end up making mistakes. So Jordan, if you're ready, go ahead and turn on your video. And if Dr. Palakanis, Dr. Saavedra, to the extent that you can stick around, you are welcome to, would love to have you. We recognize too that you guys are being pulled in a number of directions. You're going to have to get going. I also am going to have to get going at the top of the hour, and Ray will take over moderating, and between Ray and May Kwong, you guys will be in good hands. So Jordan, go ahead and take it away. Do we have Jordan on the call still?
Jordan, you're on mute.
Hi there, this is Ray Dizon. I see Jordan is on the call, but I'm not sure if he's having technical difficulties.
Let's go ahead and move forward to May's part and get started on that. Oh, here he is.
Can you guys hear me any better now?
Yep, now you're on.
Okay, so we're going to talk a little bit about some of the telemedicine technologies. We have to take a really high view of this, and we can't talk about specific technologies at any depth. What I'd like to do instead is talk a little bit about some of the trends that we can see, what we can kind of expect in terms of what technologies are going to be in demand, and some basic questions that people can begin to ask themselves to make good technology decisions in the coming days and weeks here. So if we can go to the next slide. So we want to take a look at what some of the expectations we have from patient side. A lot of the care that we expect to see expand rapidly are direct to consumer patient visits, visits in the patient's home, visits that reach out to the patients where they live. We expect to see the mobile devices to be a key platform for reaching out to patients. So using the patient's own mobile devices, whether that be phones or tablets, we can also expect to see laptops, things like that. In the provider side, we expect to see more of an expansion in web-based, link-based. We think that that's kind of how the easiest way for folks to connect is to send a link out and have a link-based video conferencing. Web-based is really the place where we expect VTC to expand the most. This is a trend that we've been seeing over the last several years, and we expect it to continue. The reason for this is it's just difficult to increase capacity for on-site server-based video conferencing at the rate that might be needed in the future. And with web-based video conferencing, it's easy to expand endpoints with laptops and USB types of peripherals. The other things that we want to talk about are what we can expect to see in platforms. Again, we're looking at web-based platforms. The questions that we've had come up most often is, how do I get a secure platform? And we hear a lot about HIPAA compliant platforms. And we always like to point out HIPAA compliance is not a technical specification. There is no technical specification for HIPAA compliance. The guidelines around being compliant are that it does need to be encrypted. Most platforms are going to use end-to-end encryption for their video platforms. We also highly recommend that systems sign a business associates agreement with their video platform, so that the information that platform is holding and maintaining for you, you can make sure that the procedures and policies that they have in place will safeguard that technology, or they're joining you in the process of safeguarding that information. Key factors that you need to consider when you're looking at these platforms are, how scalable are they going to be in the short term? If you need to get more seats rapidly, how easy is that going to be to do? Reliability. Are they centrally located, or do they have regional facilities that provide coverage for your area? Are they going to be able to kind of handle a lot of additional traffic in the future? And then ease of use. If we're reaching out to patients in their homes, and if we're reaching out with new providers that have not used these types of technologies before, it's going to be very, very key that the technologies that we use are simple, kind of push button, and really straightforward. Can we go to the next slide? We also want to talk a little bit about what some of this might mean for the national infrastructure and bandwidth. We are already beginning to see an increased demand, and that demand is going to increase even more as more healthcare moves to virtual services. We can expect to see education move to virtual services as schools are shut down physically and a lot of classes move online. There's also a growing portion of our workforce population that are working from home. We can expect to see bandwidth increase from that. And then just as a fact of social distancing, if we are not going out to the places that we normally go to and we are at home, there's just going to be more consumption of media and other resources that increase that bandwidth. So what are some of the things that are kind of being done? ISPs and carriers are looking at ways to kind of increase access to bandwidth, especially for consumers that have had historically lower access to that to bandwidth. So the FCC Chairman Pai from the FCC has put out the Keep Americans Connected pledge, and a lot of ISPs and service providers have signed on to that. And the agreement is that for the next 60 days, they plan to not terminate. Not terminate plans, and that they would waive late fees and provide more access to Wi-Fi hotspots. So instead of the pipe is actually people are getting more access to the pipe. And the speeds and the caps for a lot of ISPs and carriers are being boosted. So we can actually see a lot more of our population have more access to the bandwidth. One of the challenges with this is that pipe is not growing. The infrastructure that we have for this emergency is the infrastructure we have for this emergency. So depending regionally on what that infrastructure looks like, and kind of nationally on what the bandwidth limitations are, we may start to see network congestion in ways that we haven't seen kind of on a national global scale. And what that really will kind of come down to is there will be some attempts, we think, to kind of prioritize healthcare and education traffic. But currently in our environment, it's really hard to do that. There are no ways to really signal out what that kind of, what traffic is related to that kind of critical services versus what the rest of the traffic is, especially if we're reaching out to patients in their homes. So there will be attempts to kind of prioritize that data. What that's going to look like and how that's going to be accomplished is really a question. And like everything else we've talked about here, this is going to change on a day-by-day, a week-by-week basis, and we can expect the unexpected in this space here. And again, the super high-level overview. Please contact us through the telehealth resource centers if you've got questions about your specific program and you have specific questions about technologies that you're interested in using. We can talk about those in more detail, but we wanted to provide kind of a high level of what we're seeing in the technology space. Thanks, Ray.
All right, thank you, Jordan. I'm sorry, Jonathan. Thank you, Jordan. So, you know, I wanted to take a moment to just say thank you to all of our speakers. I know that some of you have dropped off. And so in this time, we'll be transitioning to our next agenda item, which is a telehealth policy overview. I'll be introducing Mei Kwong. She is the Executive Director from the Center for Connected Health Policy. CCHP is the nationally designated telehealth resource center for telehealth policy. So Mei, whenever you're ready.
Okay. Could you advance the slide, please, Ray?
Sure, I have a lot of things going on right now, so just give me 1 second.
Okay, and one more. So I always have to start off with a disclaimer here. So information I'm providing today is just information. It is not legal advice. So please keep that in mind. If you are seeking a legal opinion, please seek out legal counsel. This is because of the funding that we received. We are grant funded by HRSA, the federal government, so I cannot provide you with a legal opinion. Also, if I happen to mention a piece of equipment or a company, know that neither I nor CCHP have any type of financial arrangement or relationship with such an organization. Next slide, please. So I'm just going to, next slide, go through a couple of these slides really quickly. They're just introductory slides. Next slide. Next slide. One thing I do want to point out is that CCHP does look at all of the telehealth Medicaid policies, laws, and regulations for all 50 states, and we have that up on our website and it is publicly accessible. The information is good up through October 2019. We're actually working in the midst of our spring update, but that gives you kind of a baseline. As I go through my presentation, you'll see things are shifting a lot and they're changing rapidly on the state level as well, particularly around the Medicaid programs. But at least the information will give you a baseline of what they sort of have out there now, with the caveat that there are a lot of changes going on with executive proclamation, guidances, and changes in the Medicaid program on the state level too. Next slide, please. So as Dr. Neufeld pointed out, this is going to be pretty high level, pretty quick, and I'm going to apologize now. I'm a fast talker. So this is being recorded. You can go back and listen to the recording if you missed something that I've said, and also know that you can also reach out to CCHP or any telehealth resource center to answer a more specific question. But one of the things that I understand people are confused about, and I've been monitoring the questions in the chat and then the QA, is what's going on the federal level? There's been a lot of changes. What does the passage of some of these bills mean? What is CMS doing? So this is currently what is going on right now with Medicare. And I want to stress that. This is Medicare we are talking about right now for this particular section. So underneath Medicare, when you're talking about telehealth reimbursement, there's typically restrictions on what you can do with telehealth underneath the Medicare program. And it's broken out into a couple of chunks of you need to have the patient in a certain type of location, both geographically and where they are actually physically located, the site. You also have a limited list of providers that will be reimbursed as they provide the services via telehealth. You also have a limited list of services that they will reimburse. Medicare does not say, oh, if we cover the service in person and you provide it via telehealth, we will cover that as well. They have a limited list of services that they say we will only reimburse these services if you provide them via telehealth. They also limit the modality you use, whether you're using live video, store and forward. A lot of questions I've seen have been coming up about telephone or remote patient monitoring. That is limited as well. So what is going on now, particularly with the waivers that have been instituted? What has only been removed or changed from the telehealth policy for Medicare are the geographical limitations and the specific site limitations. So what that means now is that the rural limitation does not apply for Medicare. So you can now be a hospital in an urban area and use telehealth, and that service will be covered. Additionally, where the patient is located as far as their site is now been waived as well, which means the home is opened up. You don't need to just be in like in a healthcare type facility like a hospital or a clinic. The home can now be an eligible site. Those were the two limitations that were waived. So eligible provider limitation, that was not waived. I've seen a lot of questions about FQHCs and RHCs asking, can I now act as a distance site provider? And the answer is no, that limitation was not waived. What did change for FQHCs, I don't think really applies to RHCs, but for FQHCs, is that if you were an FQHC in an urban area, you can now act as an originating site because the geographic limitation was removed. But you acting as a distance site provider, FQHC, RHC, allied professionals like physical therapists, occupational therapists, dentists also, that limitation was not removed for you in Medicare underneath this waiver. So currently, as the policy stands, that did not change for you. Additionally, the modality did not change for you. So I've seen a lot of questions saying, can I now do these services under phone? For telehealth, no, it is still limited to video and store and forward option for Hawaii and Alaska. That also was not waived underneath the waiver that we have seen instituted so far. Services, what services can I provide? There is a limited list of services that CMS will reimburse for if you provide the services via telehealth. That list did not change. So you are still restricted to that list. It's not like other services suddenly became available. What they did say though was we will reimburse for telehealth services even if it's not treating or related to COVID-19. So that was a question when the bill first came out. It's like, is this waiver only applying to COVID-19 services or does it apply to all services regardless of whether it was related to COVID-19? And it does not have to be related to COVID-19, which is very important. So if you are a practitioner, a physician treating somebody and they don't have COVID-19, but you don't want them coming into your hospital or your clinic, you can still use telehealth and get reimbursed by Medicare. Additionally, what they said was the facility fee. They said that you will not get the facility fee if you are in one of those locations that are underneath this temporary waiver. Going back to my example of an FQHC in an urban area, you suddenly become like an eligible originating site underneath this waiver. You will not receive the facility fee. That does not apply to you. It only applies to the pre-COVID-19 eligible types of sites. They were the only ones who get the facility fee. Oh, next slide, Ray. Other things that happened as well. There was a question there. Underneath the bill of 6074, it said, well, for a provider to provide these services, you need to have a pre-existing relationship with the patient. What CMS has said that they will not do audits to like check to see if you have that pre-existing requirement or that pre-existing relationship. So they're saying like, we're not going to ding you if you suddenly use a new patient or have like a new patient relationship here. So that is what they have said was they're not going to ding you, and that's exactly what they said. So you're going to rely on what they have promised here of not auditing you if you are dealing with like a new patient via telehealth. Do co-pays and out-of-pockets still apply? Again, they have said that the Office of the Inspector General is providing healthcare flexibilities, providers flexibility to, alter the amount or waive the fees. And this can be very important because I know there have been concerns about people about start clause and anti-kickback of like, if you do that, do I get in trouble because it looks like it's an incentive in some ways? OIG is saying, we're going to give you some flexibility on that. Can smartphones be used? So underneath 6074, they said, yes, you can provide the service over your smartphone. And this gets back to some of the things that Jordan was talking about, like the how to ensure that there is some sort of safety there, or some sort of quality, and like how you're providing services. So be mindful, and I would really TTAC's more of like the expert on like, you know, what you should consider if you are using your smartphone. But what Congress has said, and what in 6074, is that yes, smartphones can be used. How much flexibility do you have under HIPAA? Is FaceTime okay? So there is actually a OCR guidance on that, and that is the link for that particular guidance. What they will say is like they will exercise enforcement discretion and waive penalties for violations. And I think Jordan did mention this. He said something, or Kerry actually did as well, is that, you know, they may be waiving this HIPAA restriction on the federal level, but keep in mind, you've got states that you're operating in. They may not have necessarily waived their requirements on protecting patient information and health information. And a lot of times states will actually have more stringent requirements than what HIPAA has as well. So keep in mind, while the OCR is saying like, here's a guidance, we're giving you some flexibility, it's still gonna depend also on like what the state that you are operating in. Because if you're crossing state lines and you're operating in another state, it might also depend on what they allow as well. Licensure. So there was an announcement of, you know, the licensure was waived. Does this mean now that I can operate across state lines? Again, what they did was they waived the licensure requirement underneath Medicare. And what that means is there's regulations within Medicare saying like, if you want to get paid, you need to be licensed in the state the patient is located in. They're waiving that requirement. However, licensure is based on a state-by-state basis. They control actually the laws and regulations around licensure. So you will still encounter state laws, state regulation regarding licensure. And that's going to depend on what the state has decided to do. And I'll get more in detail in that in a little bit, but it's really complicated because states are all doing different things. Now, the link at the bottom there, that CMS FAQ, that just talks about everything I did just a moment ago, that gives you a little bit more detail. So that's like another resource that you can click on to like get more information as well. Next slide, Ray. DEA, what is the DEA doing? So because a national emergency was declared, the DEA, that kicks into one of the exceptions in the Ryan-Haight Act. For those who are not familiar, under federal law controls the prescription of controlled substances. It's under, and the telehealth section, they call it telemedicine in the act. Under the federal law, the telehealth section that relates to telehealth, prescribing is called the Ryan-Haight Act. That's like your shorthand for it. And they have exceptions on how you can use telehealth to prescribe without having to see the patient in person and do an exam. One of the exceptions was if a national emergency is declared, or if a state of emergency is declared, this kicks in, and DA said, emergency declared, this kicks in. And so what it is now saying is that you can prescribe a controlled substance if the prescription is for a legitimate medical purpose by practitioner, usual course, and telemedicine communication is conducted audiovisual, real-time, two-way, interactive, live video, essentially. And the practitioner is in accordance with applicable federal and state law. State law, I want to emphasize that, because again, you may have states who have a bit more stringent requirements in regards to prescribing of a controlled substance. So this is like another way for people to use telehealth to prescribe a controlled substance. And I know there's been a lot of questions about mental health and some around substance use disorder, and like, what can you do in this particular situation and prescribing. So this is like another avenue for you on prescribing controlled substance that has kicked in. Next slide. And that's a link also to the DEA's information on that. Fqhcs and RACs, a lot of questions around that. So I want to reemphasize again, you cannot act as a distance site provider in Medicare. So that option is not available to you. Will that change? Possibly. There's a lot of possible, a lot of like changes going on right now on the policy level. It could possibly change. We may see a change in a few bills that are coming out. Who knows? I don't have any like definite information on that. But currently, right now, Fqhcs and RHCs cannot act as a distance site provider in Medicare. Facilities excluded from acting as originating sites due to geographical limitations are now eligible. I said that that opened up for you because they removed that geographical limitations. But there is a set of other services that Medicare does not call telehealth. They call them other things such as, technology-based service or technology-enabled services that Fqhcs and RHCs can use that use technology, but is not considered telehealth by Medicare, and that they can act as that essentially distance site provider to provide those services. Next slide. And these are those services, and you've probably heard them as well. So there's the virtual check-in codes. That is literally what it means. Check-in, quick check-in, 5 to 10 minutes. You can do it via phone. You can do it store and forward and live video option. Fqhcs can use this, RHCs can use this. I will warn you, it does not pay a lot because it is considered a quick check-in. It's like about $10 or $14 or something like that, but it is like an option for you to use. Interprofessional internet EHR consultations or e-consult, that is another option that providers can be used. It can also use phone, live video, or store and forward. That is not available to Fqhcs and RHCs. Then there's a whole bunch of codes that really fall into the remote patient monitoring type of codes. So they're chronic care management, transitional care management, principal care management, and that they're kind of mixed. So Fqhcs and RHCs can use some of these codes and they can't use some of the other ones. So it's going to really depend on where you fall into the definition of the code that you want to use. If that would qualify for an Fqhc and RHCs. And then digital e-visits and online medical evaluations. It's through an online portal. Again, I don't believe these are available to Fqhcs and RHC, but for other providers, this may be another option for you in providing services through technology. And because these are not considered telehealth services underneath Medicare, you do not have the restrictions that you see underneath Medicare. You don't have that geographical limitation, you don't have that site limitations. These are a little bit more broader for what type of providers can utilize these services or provide these services. I will warn you, a lot of them do have their own kind of requirements and restrictions just by how they're defined and who can use them. But as far as those telehealth limitations underneath Medicare, they will not apply. Next slide, please. So what's going on in the States? So pre-COVID-19, this is what we essentially saw underneath Medicaid fee-for-service programs across the states. Everybody was reimbursing for live video for some type of service, store and forward remote patient monitoring, a lot less popular. Next slide, please. A lot of states, the majority of them had some type of private payer law on their books. So that is another thing that was there, that was available, but they ranged from various things of limiting the type of modality that you can use, like it's only live video, to also say, state health plans, the state saying health plans, you can reimburse for telehealth delivered services if you want to, all the way to states that were more mandated laws that said, health plans, you shall cover the service if it was delivered, regardless if it was delivered via telehealth or in person. And by the way, you will also pay the same amount. So all the states kind of fall into different regions there. Now this is pre-COVID-19. When you had COVID-19 and we realized how much of an urgency situation we were in, you had a lot of changes that were made. So Ray, next slide, please. So what's going on right now? States are updating Medicaid policies to utilize telehealth more broadly, and this is changing every single day. So, and they're doing it in different ways. So if you ask me what is it like across the state, I can't tell you because each state is doing their own thing on this. They've originally had their own telehealth policies to begin with. So they're doing things differently and going at what they think is the most appropriate use for their state, the most appropriate case for their state. Some states were in probably a better position than other states and didn't have to make as many changes, but even those states are still finding there's still issues and barriers there that they need to address. But a lot of the changes, a lot of declarations that we're seeing from governors or from executive agencies or even states may be trying to do legislation, a lot of what they're focusing on are licensure waivers. So again, connecting with what was done on the national scale with Medicare, you do see some states looking at that licensing issue and like waiving it, saying, and basically on the lines, in this emergency situation, we're waiving this particular requirement. They may be saying that they're waiving it Medicaid, they may be going a little bit broader. Expanded policies to include provision of services via phone. That is another thing that we're noticing. So phone has been typically not considered a part of telehealth. You find a lot, most states and even Medicare, when they define telehealth or telemedicine, they have excluded phone. So what you will probably see are a lot of places or a lot of states saying, like, we are going to allow this via telehealth or phone, because their definition of the term telehealth did not include the phone. So we're seeing them trying to expand policies with like allowing phones. Waiving of co-pays and deductibles. We're also seeing a lot of states saying, like, we're going to make sure that we waive the co-pays and deductibles, or that there's not a co-pay or deductible related to like COVID-19 testing. That is also going on. So these are the common themes that we're starting to see so far for the states who have issued something specific related to telehealth or can impact telehealth. Ray, next slide. I want to take a moment to talk about 1135 waivers. So 1135 waivers are things that states can submit to the federal government and say, like, hey, we need this change from some of the federal regulations so we can have more flexibility to deal with this. So Florida had one approved. It was actually the first one that was approved by CMS. California, I know, has submitted one, and I think I just came across my desk, another state had just submitted one. There may be other submissions I'm not aware about, but I picked out Florida and California as examples, and like some of the things that they requested that were in there that could impact telehealth. So Florida asked for being able to pay claims by out-of-state providers that are not enrolled in their Medicaid program. So I believe practically all Medicaid programs for every state has said you need to be an enrolled provider, provide services, and for us to pay. So Florida's asking, we need an exemption for that, so we can like have these out-of-state providers to pay, so we can pay them out and they can provide services to it. So that is something that has like implications for telehealth. California submitted a waiver. They were more specific in what they were asking for, and I just pulled out two examples. So getting back to our Fqhc, RHC examples, and I stressed really heavily that they cannot act as distance site providers underneath Medicare. Medicaid is a different story. Some states allow Fqhc and RHCs to act as a distance site provider. So while they may allow that, they may run into other types of regulatory issues where they hit against like a brick wall of like trying to use telehealth more expansively. And that's what California encountered, where they said, like, we need you to waive this for us so we can allow Fqhcs to have like more flexibility in the tools that they use. And one of the things that they asked for an exemption and waiver on is the face-to-face requirement for an Fqhc and RHC, and then like a general request for greater flexibility to use the phone in telehealth. Nobody has asked me, but I'll give my recommendation. I would say if you're a state, you're submitting an 1135 waiver, you want to use telehealth, and you especially want Fqhcs and RHCs to do it, I would ask for like a pretty broad waiver saying, like, you know, allow Fqhcs to use technology, and I would say technology, I would not limit it to telehealth, so you can include things like phone, technology-based devices in order to like provide care, and any types of a waiver to, you know, any barriers that they may encounter in doing that, and see if like that works, so you're not hitting up against like these quirky little policies that are in place that you don't realize are there, and then suddenly like impede the use of telehealth for some reason. Next slide, please. So some of the resources that we have available is our CCHP website, which our 50 state is located, and you can also subscribe to our newsletter, because one thing that we are doing, what you see on the right-hand side of your screen, is a fact sheet that we put out with like all the updates of the telehealth policies that are going on. We are trying to update this on a daily basis. We're also trying to work out something on our website to like have it up there, so it's kept up a little bit more constantly. That's just the front page of it. That's like the Medicare changes that are on there, but we have other policy changes on the other portions of the document, as well as state changes as well. So that is another resource that you can have available to you. And I think that is it for my slides. And probably if Jordan's still around, we can try to answer a couple of questions.
May, I was going to try to answer a few right off the bat, if it's okay.
Yeah, go ahead.
All right, so you've had quite a few questions about billing, and I can help do a 30,000-foot overview about billing. numerous people have asked about which CPT codes are allowed for telehealth. When it comes to CPT and E&M codes, there are not specific codes associated with telehealth. You're using the same CPT and E&M codes that you use in your standard practice environment. You're just using a place of service of 02. And then whether or not you're adding a GT modifier or a 95 modifier, that's going to be dependent upon the insuring organization that you are billing to, because some organizations ask for modifiers, some don't. The place of service pretty much remains the same. May you also mention virtual check-ins, and I saw quite a few things about virtual check-ins. Very, very important for anybody who's going to bill under that. You cannot have seen the patient for the same E&M condition 7 days before or within 24 hours of the virtual check-in. So it's got an interesting time limitation to it that a lot of folks miss when they do it. As far as waiver of co-pays, that does not apply to remote patient monitoring. That only applies to telehealth. And then one person asked a question about, can more than one provider bill RPM? The answer to that is no, only one person can bill for RPM services. You can't split that up between a couple of different people. And then, as being a good nurse practitioner and wanting to be mindful of our licensure practice, remember that the provider has to be licensed in the state they are standing in at the time they provide the service, and the state that the patient is in at the time they provide service. If you go on vacation to Florida and you're doing telehealth from Florida, you need to be Florida licensed while you're doing it. So that's a confusion point that I get a lot in the real world. And then along that same line, states have specific consent regulation language. So there isn't just one global language associated with consent for a patient. Make sure before you're providing services that you understand the state specific consent language for telehealth.
Mm-hmm. And also for some of those virtual codes, those technology-based codes, there's a consent requirement in there as well. So be aware of that. CCHP did release a sort of how to bill in Medicare fee-for-service billing guide earlier this year. Some of the information is a little out of date, like the geographical limitation. You'll see in there like, oh, there's the geographical limitation underneath Medicare, which has been waived now because of like of current events. But it does give you sort of like a starter, especially if you are new to like billing for telehealth. It does give you a starting point of like, you know, what modifier do I use? What are some of the codes that I need to look at? So you can go to our website. It's underneath our resources tab to like go and download that as well. As I said, it's a starting point. It's some of the information is slightly out of date because of HR 6074 being passed and like removing the geographical limitation, but it is a starting point for you there, and probably will answer some of these questions that we've been seeing coming through here. So, Jordan, yep, go ahead.
Can I hit you up for some legal advice here? One of the respondents said, oh, you don't have to be licensed in the state the patient's in. That is my understanding, and always has been, that you're practicing medicine in the state that the patient's in, so you must be licensed in both.
So my question then is that I can't give you legal advice, and my answer to that is they have said, states are very clear. I don't think of any state, I can think of any state that said like, okay, so let me put it this way. States in general require you to be licensed. There are sometimes exceptions that are very rare where they will say, oh, if you're just providing a one-off consultation, that's okay. Or if you are within 50 miles of the border and that, you know, you can, and there is like nobody available, that is okay. Very, very narrow exceptions, but from my study, all the states are saying you must be licensed in our state if you are providing services on a consistent basis to a resident in the state.
And it even gets a little bit fuzzier than that too, that you have to be cautious if you're a non-physician provider. I know my providers that I have that are PAs cannot function in Nevada because Nevada law requires that the supervising physician and the PA be physically in the state 1 day a month providing care together as part of their supervisory relationships. So it gets very tricky, and you know, that when you're talking about practicing across state lines, you always need to be mindful that you are understanding not only the state of your originating practice, but the state in which you're practicing.
Mm-hmm. I would also, because I think there are a lot of new people here, I would also caution you to, not giving legal advice, this is just my opinion, check with your malpractice carrier as well, because if you start going into another state and you're offering service there, your malpractice insurance may not cover those services that you're providing in another state, because they may not operate there, or they may not cover services delivered via telehealth that may not be in your plan. Just double check with them as sort of something to be mindful of. So I'm gonna see, Jordan, is there anything you wanted to add?
Yeah, I had two kind of quick comments, just kind of looking at some of the stuff in the chat. The first one is, if you have specific questions about your particular program, I recommend that you contact TTAC directly through our website, the Telehealth Technology Assessment Center. One of the things that we say is that technology solution for one organization is a technology solution for one organization. And it really does, even in a crisis situation, it's gonna be worthwhile to do a needs assessment and really look at what you're trying to build and the population that you're trying to serve, and that will vary. So we really do want you to kind of reach out to us, and we're happy to talk to you about your specific telemedicine needs. That said, we are grant funded and we can't recommend specific technologies. We can talk to you about what's on the market. We can talk to you about what your need set is and what kinds of solutions might fill your needs, but we can't recommend a particular solution. The other thing that I wanted to really encourage people to do is kind of plan beyond the crisis a little bit. There were some really good points that were brought up by our speakers, saying that, you know, this is changing the paradigm of kind of how we approach telemedicine. So when you're choosing technology, or you're setting up policies, or you're looking at this stuff, make sure that you're building something that will be able to last into kind of some normal business operations, and that doesn't, we have to get up to speed quickly in order to kind of handle some of the crisis issues that we are having. But what you build today, it's kind of the prototyping problem. Whatever you prototype tends to go into production. So whatever you build, make sure you're taking the time and resources to make something that can scale and that you can use reliably in your normal business, normal day-to-day operations. And let me give out that website again. If you go through the National Consortium website, you can get to TTAC, but we are the Telehealth Technology Center, so telehealthtechnology.org, and that'll get you to our website. You can use the contact us. We have a variety of toolkits on there as well, around video conferencing, around other resources that you can look up and get some of the answers. So, yep.
There was a follow-up question to the licensing, asking, like, I understand that you need to be licensed in the patient state, but why do I need to be licensed in the state that I'm located in? It's because a lot of times when you get licensed in the patient state and you're talking about telehealth, they require you to be licensed in where you're located. It's also going to be dependent upon the payer that you have. If you're dealing with like a Medicaid patient, they also have rules like that. And we did not even really touch on private payers. So just very quickly, some private payers have been saying that they will waive deductibles and co-pays if you are accessing services via telehealth, or they're making telehealth services free of charge for a certain period of time. So private plans, when you look at them, their policies will vary depending on what's required of them in the state and also what they choose to do. Medicare Advantage plans. I did not talk about Medicare Advantage plans because recent policies do not impact the Medicare Advantage plans. Medicare Advantage plans, there was a law passed about 2 years ago, which gave flexibility to Medicare Advantage plans to use telehealth more widely in like the location of the patient, the modality that they use, not the services that they will provide, not the list of providers though. So they still have that limited list of providers. And the Medicare Advantage plans actually had a lot more flexibility than what I had gone over, which was Medicare fee for service. So Medicare Advantage plans, you're still also going to get a variety of like what they are covering. Their baseline is the fee-for-service stuff that I just went over, but they could actually do more, and they have that flexibility to do more. So health plans, private payer plans, that's just like a very rough overview of like how they work with telehealth and where it applies to them.
I'd throw one other cross-state consideration for folks to put in there. While the COVID-19 waivers allow for a loosening of the Ryan-Haight Act, DEA still requires you to have a license in each state that you're prescribing in. So if you're prescribing a controlled substance across state lines, you must have a DEA license in each of those states, as well as a state controlled substance license if the state has that.
Yeah, question about consent. Again, it's going to vary. Actually, a lot of states do have like consent requirements. Medicare, underneath telehealth, they don't. Underneath some of those technology-based service codes, like the virtual check-in codes, they do have a consent requirement. So again, it's going to vary on what you're trying to do, where you're trying to do it, and who you're trying to get money from to do it. So like I said, it was complicated before COVID-19 because everybody was doing different things, and then with COVID-19 and all these like new policy changes or emergency waivers and so forth, it's made it even a little bit more complicated. And then some of the consent requirements may be waived with like emergency waivers or proclamations that states are making too.
Right, we're getting lots of questions about how the waiver has superseded what we're talking about. And I think, again, it's important to point out the waiver is associated with federal requirements and Medicare. The state regulations are still in place unless your state waives any of these requirements.
So we are a little bit over. I don't know what, Kerry, what your schedule looks like. I can stay on for a few more minutes to try to answer some more questions. And Jordan, I don't know what your schedule looks like as well. But we can stay on for, let's say, another 10 minutes.
I'm good for that.
To just get through some of these questions. Again, please note that this is being recorded. So if you do need to drop off, thank you for attending, but you will also be able to access the last couple of minutes that you missed. And we will try to answer all these questions in an FAQ that we did not get to during the webinar and have that posted on the National Consortium TRC website as well. So feel free, don't worry, you won't be missing anything. We're recording this. Let's see, what are some of the other questions that we are getting on? Still a lot of questions about Fqhcs. So Fqhcs in urban area. Again, if you are talking about Medicare, you only qualify as an originating site, and you will, if you suddenly qualify underneath the waiver, you will not get the facility fee because they do not pay that to people who are entities that are qualifying underneath the waiver as the originating site with this with the new change. So that means like the ones that are in urban areas. So yeah, so Fqhcs, that is like a really hard thing on you as well, because you don't qualify as a distance site provider, and then if you suddenly qualify to act as an originating site underneath the waiver, they're not going to give you the facility fee either. So that is an issue. Again, I have heard rumors that they may be addressing this in a future bill related to COVID-19. So, but that's just like rumors I've been hearing right now. For Medicare, yeah, no, you can't act as a distance site provider. And if you're suddenly like qualifying underneath the waiver to act as an originating site, you won't get the facility fee. Check out Medicaid though. Medicaid may be a different story for you, but that's going to vary from state to state.
A couple questions have come through about using telehealth for risk adjustment. If you have a Medicare ACO, then you can use telehealth to meet risk adjustment criteria, but there is still a debate out as to whether or not an annual wellness visit is approved through a telehealth visit. I've gotten varying responses from CMS as well as from my states on that, but I would say from just a standard RAF creation, you're okay. From an annual wellness visit, be careful and ask CMS.
General question on what is an originating site and distance site. So my apologies, I do get into like throwing terms that if you're a little bit newer may still be confusing for you. So originating site is where the patient is located, and a distance site is where your provider who's doing the interaction over telehealth is located. So when we talk about that for like an Fqhc acting as originating site, that means where the patient is located. They're located in an Fqhc facility or like a hospital or doctor's office, something like that. That's your originating site, is where the patient is. Distance site, and you might hear distance site provider, that is where the practitioner or provider who is like interacting with the patient like over technology is located during the time of the telehealth interaction. So my apologies if we didn't go over some of these terms. We've just gotten so used to like saying them. We figure everybody understands.
Someone asked if there's any extra documentation associated with telemedicine visits than face-to-face. No, you're using the same form of documentation and you're held to the same level of documentation. Consent may be different, and that's something that you need to check on.
Okay, let's see, what are some of these? We're trying to, there's some of these that are very related to each other, so we're trying to like get a cluster of questions and answer those. Oh, Kerry, this is actually an interesting question. There are also quality of care issues that are brought up. I teach NPs how to deliver telehealth care and meet all the national guidelines. There's some real difference in telehealth care and face-to-face. Depends on equipment you are using and what the counter is for. Patient safety is always upmost in our minds. Make sure we check with your professional association. So how do you guys deal with that, those types of issues or questions at Intermountain?
Well, I'll tell you, when it comes to deciding what does or what does not constitute a service that can be provided via telehealth, it's very much like I like to describe to folks that I was trained in the Navy, and so I have a lot of procedural-based skills that the average nurse practitioner does not have. So a patient that I might see in a primary care setting, if I'm seeing them in person, I would do a procedure that maybe another person with the same degree as mine doesn't do. It's individual provider. Now, as far as what can you do, the reality is if you have unlimited resources, you can do just about anything. But the even better news is nowadays the peripherals involved and what you can send out to patients to assist you in a telemedicine visit, the prices have gone down substantially. I'm not going to name a name, but there's a set of peripherals that can be bought at Best Buy for under $300 that basically create a virtual kiosk for any home environment. And then it goes even from there. I've worked with teledental equipment. I've worked with tele-ultrasound equipment that is very low cost. There's a lot of different peripheral devices available there. You can have a telehealth visit with nothing more than you and the computer and your patient, or you could have the patient have peripherals at home, or we also have kiosks here at Intermountain, so that we have virtual clinics that folks can go into and utilize the kiosks for obtaining services.
So there's a question regarding like virtual check-ins and whether like some of those requirements were waived, like Kerry, what you mentioned, like, you know, can't be within 7 days before. No, they did not waive any of those as far as I'm aware. Those are still in place. So no, none of those little limitations, you know, you didn't have the telehealth limitations, but you had all these other types of limitations to use the code. Those are still in place as far as I'm aware.
Someone asked, how do you check how do you document vitals if you do not check them personally? That one I get a lot in questions. You can have patient-reported vital signs if the patient has equipment at home, but I think one of the biggest misconceptions that exist out in telehealth is that vital signs are required in order for a visit to meet the criteria of a standard E&M code, and the reality is no, you do not have to have vital signs. But if vital signs are essential to you providing good practice, then you need to have to find a way to make that happen, whether it become through remote patient monitoring devices or through patient-reported outcomes. Again, it's an individual case-by-case basis. Looking, reading.
Okay, yeah. We're reaching out. We got 1 more minute here. Jordan, do you see anything that you want to address?
The one that keeps coming up is for regions with really low bandwidth that don't have access to mobile. There's questions about phone, and we talked about that a little bit. But and I think you talked about it specifically for FQHCs, May, but is there any other kind of guidance of how how care can be delivered over the phone and how that fits into the reimbursement and policy?
So I'll let Kerry talk about maybe from the clinician viewpoint on like when it's appropriate to use phone or something. I mean, I'm not a medical professional, so I'm a policy person. But from my like kind of policy person view, I'm thinking phone's not appropriate for everything. So you probably only want to use it for a couple of things. So on the policy end, I'll reiterate this in that before all this happened, actually a lot of states have in their policies or on their books a specific definition for telehealth and telemedicine, and it does not include phone in there. They've actually explicitly excluded. So when you say like, oh, well, they waived the telehealth requirement, that does not mean like phone is included in there. So that's why you'll see a lot of states saying like, oh, give us flexibility to use, we'll give you flexibility to use telehealth and phone, because they realize it's not underneath their definition. If they just said telehealth, phone is still going to be an issue. But in this particular situation, you probably do need to give all that flexibility to a provider, because not all patients are probably going to have that technology available to them, so they want to use the phone. That may be the only way to reach them. And I'll let Kerry just step in on like, you know, the clinician side of things.
Yeah, absolutely. I frequently, when folks ask me about the use of phones, I say, well, why are you using a phone if a video option is available? Because more often than not, the telephone technology without a live video interaction is not reimbursable. And so when possible, and now more and more, even I live in a very, very rural part of the country. Well, I've actually lived in many rural parts of the country. Now it's becoming more common that while patients may not have internet, broadband internet, or they may not have cellular access, that they have satellite access that allows for a web-based conversation to occur. So I'm always mindful of asking my patients, what resources do you have at home? So you're going back to rural Wyoming. What do you have access to? Do you have access to internet? Do you have access to a phone? While you may not have the same quality of interaction, there may be a delay and lag in the audio-visual, you're still able to make that happen even at very low bandwidths. And what happens now in the technology we're using nowadays versus even 5 years ago when I was doing it, they don't require anywhere near the bandwidth that we used to need in order to have a good telehealth visit.
Okay. All right. I'm going to end this, but there was this question here that just came up. Simple question. I just wanted to check on a COVID-19 sick patient over the phone. Is this telehealth? Will it be covered by FTCA? Kerry's shaking her head. It's not considered telehealth. As far as FTCA, probably
make sure call them on their smartphone.
Yeah.
Have that video FaceTime, because now you can use FaceTime and Skype for the short foreseeable future. You can make that call, and it would be a billable call using a interactive audio video service. But calling them on the phone to check on them, no.
Since you're talking about FTCA, I'm assuming you're like an FQHC, so you could use virtual check-in code. So that would,
as long as you haven't seen them 7 days before,
yeah,
or 24 hours after. And I'm thinking if you're checking in, you probably saw them 7 days before.
Yeah. All right then, so we are at time here. Again, we thank everyone. We thank your patience in like us trying to get through the questions. We will go through them. The TRCs will go through them and post them later. Dr. Saavedra had to run. Dr. Neufeld had to run, but I do want to say personally thank you to Dr. Palakanis. I hope I pronounced it right. Kerry for like, you know, your great presentation, and I know how busy you are for taking time out of your busy schedule for doing this. I will say the TRCs have been inundated with questions, but really the people who are seeing this the most and like doing like a heroic job are people like Kerry and Dr. Saavedra, who's out there on the front line. So we just want to send our thanks to you guys.
Thank you.
Thank you.
All right.
May, really quick, we have a few more slides before we close out. I don't know if you want to go over them. I could go over them.
Sure. No, I'll just go over them really quickly. Thank you, Ray, for reminding me. So people are asking like, and I knew there were a lot of questions about teledentistry. Hey, the Northeast Telehealth Resource Center is doing like a teledentistry webinar. So keep in mind, not only do we put out these resources for you, but we also have additional webinars that regional TRCs are putting on, and information for them are listed here on this slide. Next slide.
Actually, we do still have a few more, several other TRCs that are also transitioning to virtual events. So just keep an eye on our webpage for any future updates and future events that are coming.
Yeah, so the TRCs, like everybody else, are considering going to more virtual events given this current situation. We have a next webinar, as Ray said at the top, I believe. We do this the third Thursday of every month, so keep in mind for that. Get on our email list to be aware of what are the topics that are going on for the next webinar. It looks like it'll be on telebehavioral health responses. There were a lot of mental health questions in the Q&A today, so that will probably be a very good webinar for those who are more curious about the subject to attend. Next slide. We are federally funded. We're funded by HRSA, so we do ask that you fill out a survey to let us know what you thought of this webinar, what you think other future webinar topics should cover. We would take that into consideration as well, so it would really help us out if you fill out the survey and return it to us.
Yeah, and that concludes our webinar.
All right, so thank you everyone. Stay safe out there.
Thanks everyone. Bye.